I think everyone here is familiar with the Forum for Equity in Health. Um, just to remind you, this whole thing started in our third workshop, Governance workshop in 2024. And in an attempt to continue that dialogue and attempt to convert study and reflection into action, we had decided to support the JSS public interest litigation concerning the implementing the Patients' Rights Charter and standardization of rates in private healthcare institutes. So this is where it all started. All of you, I think you know me. I'm Kranti, and some of us, after writing that expert testimonial and many months later, we came together to write this paper, which documented the experiences of healthcare providers in private healthcare institutes. And it was actually quite a long journey. I mean, it took us at least 6 months. We started with a small group, and it slowly evolved into something very different from what we had imagined. But it was a great learning experience for me, and I'm sure for all the others. Kalai, Avani, Aparna, Ubu, Porchalvan, Mike, all of these were people who were worked with us quite closely. And towards the end, Aparna and Ubu were of absolutely great help. And of course, we had a lot of support from the whole of the Kudam as well. So I represented Forum for Equity in Health at the UNU IIGH symposium, which was on strengthening global health governance, defending the public interest, and holding powerful private actors accountable, which was held in April 2025 in Malaysia, Kuala Lumpur. Our paper was titled Effects of Corporatization and on Clinical Practice in Private Healthcare Institutions. That is the experiences of concerned healthcare providers. And of course, we had a lot of support from Abhay Shukla as well. Since I was there, I was trying to, I felt like all of you were with me and I was trying to send you as many updates as possible. But I really wanted to take this opportunity to share what I presented and maybe just a few things that I learned there. And then maybe I'll try and make it as short as possible, maybe just 30 to 35 minutes. And then the remaining time, we can just open it up and, discuss any ideas or suggestions or insights that all of you have. Thank you all for being here. I'm really grateful for all your support. Obviously, none of this would have happened if we didn't have this group. And I think it's also, I'd really like to thank Barefoot Academy because this is where it all started. So just to give you an idea of how the symposium was structured and the atmosphere, it was a 3-day symposium with about 200 people invited on day one. And over the next 2 days, there were just 100 people. Day one was for everyone all together with presentations from each stream that gave us a glimpse into what was going to happen over the next 2 days. And day two and day three, we were divided into these streams. So all of us didn't attend everything, but we were divided into different streams. So the streams were, stream one was food systems, agriculture, and governance. Stream two was financialization and corporatization of health systems. Stream three was climate change and health. And stream four was digital health and governance. And at the end of each day, we would have a plenary where some participants would give highlights from each session. So we were aware of the broader picture of what was happening in the rest of the sessions, the rest of the workshops. Our session was on day one. It started with Dr. Abhay, Indranil, and Indira Chakravarti, who gave a macro view of the trends of corporatization and financialization of health systems in India, looking at India as a case study. And I'll repeat what Abhay repeated there, which was that, especially in the current climate, India is a good, bad example, which means that the trend of corporatization and financialization has progressed much further than it has in other countries, but has also begun in one way or the other in almost all parts of the world. which makes them very concerned because they can see the later effects of it in India. So this is why they were interested in looking at what has happened in India and maybe learn from some of our mistakes and some of the things that we have done, to try and see what can be done in their context. So after Abhay, Indranil, and Indira, I presented a more bottom-up voices from the ground, experiences of healthcare providers working in private healthcare institutes, which I will now present to you. I'm going to share my screen. I hope everyone can see my screen.
Yes, yes,
Yeah, okay, thanks.
I can.
Good. Just give me a second, please. Sorry, I seem to have lost it. Just if you can just give me a minute, I'll present my screen. Okay, so I started with um, just an overview of what I was going to present. So starting with historical perspective, what were the aims and objectives? How did we do it? What were our findings and how we think this can move forward? Um, so over the past 5 decades, India's healthcare landscape has changed profoundly. From the 1950s to the 70s, it was largely anchored in government-run institutions and charitable hospitals. But as public health infrastructure struggled to meet growing demand, the state began encouraging private investment. By the 1990s, nursing homes and small private hospitals had proliferated, particularly in the smaller towns. The economic crisis of 1991 accelerated this shift. Structural adjustment reforms led to a decline in public health spending and opening of the healthcare to of healthcare to market forces. From the early 2000s onwards, we've seen a phase of full-scale corporatization. Large hospital chains backed by investors have rapidly expanded into both urban and semi-urban areas, and these chains are explicitly geared towards maximizing profit, setting institutional targets for revenue, procedural volumes, and specialist recruitment. The corporate emphasis on revenue generation has not remained confined to these large institutions. It now shapes practice across the healthcare spectrum, influencing individual practitioners, small and mid-sized hospitals, non-profit charitable facilities, and it has even percolated into how medicine is practiced and taught in public hospitals. So what we are witnessing is not simply privatization, but a deeper financial consolidation, market monopolization, and growing entanglement with insurance companies, pharmaceutical suppliers, and political actors. So this is the broader context in which our preliminary consultation or brainstorming session with healthcare providers takes place. So this, I'm sure all of you have seen before, the camel and the tent, which Abhay had shared with us during the first Governance workshop. So in this context, we undertook a small but focused exploratory consultation to understand how these structural shifts are being felt on the ground. by healthcare professionals themselves. Our aim was to explore how corporatization of healthcare is reshaping not just institutions and policy, but also the practice of medicine and the working lives of those within the system. So there were three basic questions we asked. Are there any specific clinical practices being shaped by commercial pressures? How is the relational fabric of care between patients, providers, and institutions being transformed? And how are health professionals responding to these pressures? And we attempted to try and be as unbiased and go into this with as few preconceived notions. So we had to sort of reframe all of this and speak about commercially influenced clinical practices and not already speak of it in a negative way. Because whatever it is, there are a few positive effects. And our aim was to just document in as unbiased a way these experiences. So to gather these insights, what we did was um, we adopted a participatory and exploratory approach centered on the lived experiences of these healthcare professionals. We invited 12 participants, including primary care doctors, health nurses, public health practitioners, specialists, and medical college faculty with experience across both public and private sectors. And we asked each participant, so the stick figure in yellow, to speak to 3 to 5 other colleagues who have either worked in or are currently working in private hospitals. And we requested them to focus not on general opinions, but on specific incidents or experiences from the last 5 years. The second stage was the brainstorming session. This was held on 10th of March, and it was structured in two parts. In the first half, each participant was given about 5 to 7 minutes to share key insights from their conversation. And the second half was a more open discussion where we collectively reflected on the themes that were emerging and how they connected to the broader systemic trends. So in practice, while some participants did conduct fresh interviews, many of them drew on longer term professional conversations from their own direct experiences working within these private hospitals. The session ran for about 2.5 hours. It was moderated by Abhay and Anand, and I was responsible for the note taking and technical coordination. So we transcribed and edited the discussion for clarity. And then Aparna and I independently analyzed the material, identifying core themes and illustrative quotes. And then through discussions and consensus, and with Anand, a lot of guidance from Anand, we developed a final thematic structure, which then forms the basis of the findings that I'll share with you now. So the first major theme that emerged was the shift in clinical decision-making under commercial pressure. Across accounts, participants described how the traditional ethos of care, where treatment was guided by clinical need and patient context, was increasingly being replaced by a consumer-oriented model. Patients were viewed less as individuals seeking care and more as clients to be directed towards revenue-generating tests, procedures, and service packages. Doctors described how their clinical autonomy was frequently overridden by managerial priorities. They were expected to follow standardized protocols designed not for clinical best practice, but for meeting revenue and procedural targets. And in some cases, explicit instructions were issued, prohibiting discussion of costs or treatment alternatives with patients, effectively constraining informed consent. Others reported that service delivery was made contingent on upfront payment, even in emergency care settings. So as one participant noted, meetings were conducted with a clear message. Prices are fixed by us and you work for us. There were also restrictions on who could perform certain procedures, which was not based on competence, but billing potential. For example, trained emergency physicians were barred from inserting central lines or intubation so that the procedure could be billed under a higher paid consultant. So the result is a practice environment that is not only target driven, but one in which medical judgment is increasingly subordinated to institutional profitability. It's worth noting here, though, that a few clinicians did report having some autonomy in their practice. Um, Participants acknowledged that they were operating within an increasingly target-driven system where institutional expectations, performance monitoring, revenue pressures were becoming very difficult to ignore. They spoke of a system where doctors are evaluated not on quality of care, but on numerical performance indicators, and key metrics included procedural volumes, departmental revenue, and contribution to institutional profit. And these metrics were not abstract. They directly impacted job security, recognition, and even continued employment. One participant noted that in chain hospitals, especially, there's constant monitoring of the income that each doctor, department, or hospital in that chain generates. And if you fall short, your job feels insecure all the time. And another one shared that if they didn't meet their targets, they would receive warnings from the management every 6 months or so. And these weren't isolated events, but routinized practices which were embedded in these institutional protocols. Several respondents spoke of the normalization of surgical interventions, even when not clinically indicated. For example, routine gallbladder surgeries. And a participant described how, after the celebrity suffered complications from an untreated gallstone, a corporate hospital launched a campaign promoting surgery even for asymptomatic cases. In another case, a neurologist in a corporate hospital was regularly advising thrombolysis for stroke patients, even in chronic or subacute cases, because it brought additional cuts and commissions. Doctors also reported that performing more procedures was linked to institutional celebration. Milestones such as the 100th surgery were marked publicly, which was reinforcing volume as a marker of value. And in many institutions, there was a clear sense that doctors had to justify their pay through procedure numbers. Um, One clinician noted that you were more likely to be questioned or even replaced if your procedural output was too low. So a closely related concern was the overuse of high-cost diagnostics without any clear clinical indication. Participants described a trend where simpler, more appropriate investigations were bypassed in favor of costlier options, like routine full body scans were offered in wellness packages, picking up incidental findings that then led to unnecessary follow-ups and sometimes even surgery. In emergency settings, whole body CT scans were used instead of the emergency fast scan or bedside ultrasound for trauma cases, despite the latter being the recommended first line. And extensive blood panels and MRIs were ordered for patients with conditions that could often be diagnosed through basic clinical examination, like altered sensorium or confusion because of low sugar or hypoglycemia. One participant recounted a postgraduate trainee who recommended a CT scan for obstructive jaundice, which is not usually the first line. And when asked why, a senior consultant replied that this is just what we do in our hospital. So this was not just about revenue, it reflected how commercial practice was being shaped by it was shaping clinical education. And students were being trained to equate costly diagnostics with better care without always questioning the rationale or ethics behind them. And investigations were recommended quickly and framed as routine rather than as decisions requiring shared judgment. So diagnostics are no longer just tools for care. They've become entry points into a revenue pipeline. In addition to overtreatment and diagnostics, participants described how hospitals routinely escalated costs through pharmaceutical and consumable practices. Doctors reported being pressured to prescribe high-cost medications and unnecessary supplements, even when cheaper and equally effective alternatives were available. One example was the use of a 4,000 rupee version of meropenem, which is a higher antibiotic, prescribed against of a 900 rupee generic. Many hospitals made it mandatory to buy medicines from their in-house pharmacies, where prices were significantly higher than outside, and some institutions even had ward-level mini pharmacies, which had further markups on supplies, particularly problematic when nurses and clinicians needed to act quickly. So this extended to basic consumables as well, like hand rubs, underpads, diapers, measuring jars were billed individually to each patient, whether they needed it or not. And there was no system for returning unused supplies, which led to inflated and unavoidable costs for the patients. So this was about designing systems where cost inflation became invisible and inescapable, and not just about sporadic instances of overcharging. Participants also shared widespread concerns about how hospitals strategically inflate bills through unnecessary admissions, extended stays, and opaque pricing practices. They described being expected to admit patients who could easily have been managed as outpatients. In some cases, hospital stays were extended without any clinical justification. And one participant recounted a practice where patients were first admitted to the emergency ward, which carries a higher billing rate before being transferred to a regular ward. Another common strategy involved assigning patients to higher cost rooms, like private rooms or single rooms, even when patients preferred or requested lower cost options. And nurses were instructed not to question or adjust these allocations. In some hospitals, general wards were removed altogether because they simply weren't considered profitable. Billing itself was described as fragmented and opaque. Patients were usually informed only of room charges at admission, while other costs, consultations, diagnostics, consumables, administrative fees were added later without prior disclosure. So non-clinical services such as customer relations staff were billed separately. And patients were typically told only the room charges at the time of admission, but over the course of their stay, additional costs were layered on. And by the time the final bill was presented, costs had accumulated in ways that the patient and their family were completely unprepared for. And once again, the doctors and nurses were caught in the middle, expected to implement these policies, but given very little say in how they were set. The next theme that emerged was the prevalence of cut practice and referral-based incentives. And just one or two of the participants shared that it is now routine for specialists to share a portion of their consultation or procedure fees with referring doctors or diagnostic centers. And these are often informal but widely known arrangements designed to drive patient volumes and maintain some kind of loyalty between providers and institutions. One of the most significant and in many ways the most painful findings from the consultation was the transformation of relationships within healthcare institutions. Let me start with the hospital-patient relationship. It is increasingly transactional, often confused, or filtered through layers of billing, authorizations, non-clinical intermediaries. Patients are confused by fragmented, opaque pricing structures, and their primary contact is sometimes a customer relations executive, not a nurse or doctor. Moving to the provider-patient relationship, doctors and nurses described how commercial pressures influence their capacity to build trust with patients. Emotional engagement with the patient's realities was displaced by the need to navigate institutional demands, sometimes leaving clinicians themselves feeling alienated from the values with which they had entered the profession. And in many hospitals, nurses were instructed to communicate the billing details, creating all this discomfort and distance between them and the patients they were meant to care for. One nurse shared that they were regularly compared to air hostesses and told to focus on customer service rather than patient care. Participants also observed systemic and interpersonal discrimination based on financial status towards the patients, particularly against those holding below poverty line cards. So in some cases, these patients were denied or procedures were delayed while cash paying patients were prioritized. And these exclusions were then internalized by junior staff, which reinforced a culture of economic and social hierarchy within care delivery. Participants also described how internal hierarchies within hospitals were shaped by financial incentives and positional power. For example, in some institutions, these patterns, which were referred to informally as admission politics, were closely tied to revenue sharing arrangements with the hospital management. And senior doctors that were cooperating with the management dominated these admission and casualty rosters to maximize income and often sidelined the junior staff in the process. Respondents also noted how hierarchies within clinical teams were shaped by compensation dynamics. So in some hospitals, once a senior doctor secured a high value package, others on the team began to expect similar remuneration. And then this created a culture of comparative entitlement where financial benchmarks contributed to inflated procedure costs. So what we're seeing here is not just external corporatization, but this deeper internalization of commercial values which are gradually replacing the relational, ethical, collaborative foundations of care. And finally, the doctor-hospital relationship has also changed. Doctors were no longer seen as decision makers, but as revenue-generating employees. Many reported that up to 90% of their consultation fee was retained by the hospital. Those who brought in more revenue enjoyed greater job security. Gender disparities deepened these hierarchies. One participant noted that some female doctors received significantly lower shares of patient payments compared to their male colleagues. And ultimately, these dynamics left many clinicians feeling deeply isolated, like replaceable cogs in a larger machine, disconnected from both decision-making and from meaningful patient-centered care. A critical structural theme that emerged was the changing nature of hospital ownership and financial control, and how that is altering the ethos and functioning of healthcare institutions. Participants described how many hospitals are transitioning from being doctor or trust-run establishment to investor-controlled entities, which Abhay and Indira and Indranil spoke more about, uh, reflecting the trend of finance-driven consolidation. Smaller and charitable hospitals were found to be taking loans or submitting to investors to compete in this intensely contested market, which is increasingly shaped by corporate or corporate type hospitals. Participants also pointed to a clear correlation between the entry of large foreign investors and changes in hospital management structures. Leadership became inaccessible, and day-to-day decisions were routed through middle managers without clinical training, who obviously prioritized financial and institutional goals over quality of care. So these shifts are not just organizational, they reflect a larger trend of oligopolization, with a handful of powerful corporate players consolidating market dominance. In some high technology areas, such as transplant surgeries, participants observed near monopolistic control. Not only did dominant corporate hospitals capture a large share of these lucrative procedures, but in some cases, they reportedly exerted influence to stall capacity building in public sector hospitals. For example, a public hospital sought to train its own surgical team for liver transplant, having long relied on an external private group. However, efforts to build in-house capacity were reportedly obstructed, allegedly due to the influence of the private partner. So in other words, corporate actors are not merely competing in the health market, they also seem to be reshaping that market to limit alternatives, deepen dependence, and ensure long-term financial control. Building on these structural changes, participants also described a corresponding shift in the everyday culture of healthcare delivery. As commercial imperatives take center stage, they are shaping how care is delivered, how staff is deployed, and how accountability is or is not maintained. In many institutions, staffing decisions are driven not by clinical need, but by cost efficiency. For example, I'm sure many of you have been aware that some hospitals hire MBBS doctors on per shift basis to manage emergency departments. And so they are not oriented, they have limited familiarity with the institution protocols, no long-term investment in the care system. They just do their shift and go. Understaffed ICUs, coupled with inadequate supervision and remote consultant oversight, have led to serious lapses in care without any strong internal review or feedback systems. Participants described frequent staff turnover, especially among nurses and support staff, driven by contractual employment, poor working conditions, and limited professional support. Participants strongly disputed the assumption that private care equals better care. They shared examples of rushed procedures, minimal communication with patients or families, clinical errors caused by inadequate staffing, and in some cases, denial of essential services due to non-payment. So, as one participant put it, this has resulted in a combination of private sector pricing with public sector levels of apathy. And ultimately, what emerges is an illusion of quality, a system where commercial presentation masks deteriorating standards of care, especially for low income or uninsured patients. So, instead of increasing competition and raising standards, corporatization in many cases is undermining both safety and dignity in healthcare. Beyond institutional changes, participants spoke candidly about the personal toll of working in a system increasingly driven by commercial logic. Many described a growing ethical dissonance, a gap between the values that drew them into medicine and the realities of institutional practice today. Participants shared stories of becoming detached from patients, of feeling like they were simply executing institutional mandates rather than offering meaningful care. And one said that it has become clear that those working in corporate hospitals tend to fall into one of two categories. Doctors who have reconciled with the commercialization of healthcare as an unavoidable cost of quality care, and those who eventually leave disillusioned by the systemic exploitation and erosion of patients' rights. A retired nephrologist shared that he felt uneasy in a corporate hospital where he was assigned procedural targets. When he attempted to work independently, he found that the infrastructure, especially for things like transplants, was insufficient, which eventually led him to reluctantly return to corporate practice. Another participant stepped away from clinical practice entirely, choosing instead to focus on teaching transplant procedures. One respondent explained that part-time work allowed them to maintain boundaries, while full-time clinicians were more dependent on the institution and therefore less able to push back. But there were also stories of quiet collective resistance. In one case, a group of staff formed a WhatsApp group to monitor the neurologist's overuse of thrombolysis, which was allegedly being done for personal commission. And the group included members across hierarchies and created transparency around each case, discouraging unnecessary interventions. And despite the structural constraints, many professionals continue to express empathy and compassion in their patient interactions. Institutional priorities are mirrored in the training of healthcare professionals, and this is also extremely worrying, where medical education appears increasingly oriented towards producing a workforce that serves the demands of a commercialized system rather than the needs of a community. Participants observed a growing shift in medical education towards specialization, profitability, and high cost interventions, often at the expense of foundational clinical skills and patient centered care. Many students effectively become super specialists before developing key generalist skills expected of a medical graduate. In private medical colleges, especially, students learn by observing senior clinicians whose behavior is shaped by institutional pressures. So, as a result, students are often socialized into revenue driven mindsets where high cost care is assumed to be high quality care without ever being taught to question the ethical or systemic implications of those assumptions. And then these trends are further compounded by the broader privatization of medical education in India. So, since the 1970s, nearly half of all medical colleges have come under business or political ownership, where profit and not pedagogy is often the guiding principle. Importantly, this trend is not limited to private institutions. Participants noted that government employed doctors often engage in private practice and deprioritize teaching responsibilities. Additionally, some educators were reported to be involved with private coaching centers where students were incentivized to recruit peers, raising questions about conflicts of interest and even cartelization within the education system. The rise of the NEET exam system in India for both undergraduate and postgraduate entry has only intensified this trend and has spawned a parallel education economy centered on coaching, test taking, and costly specialization. Patients spoke of how these environments have destabilized the ethical norms of clinical practice, creating a socially disembedded healthcare provider. And treatment is increasingly framed as a product accessible mainly to those who can afford it. So the themes that emerged from this effort largely echoed the findings from previous research on the growing commodification of health and systemic impacts. But what was new was that it offered concrete ground level insights detailing how these dynamics play out within hospital settings through specific incidents and practices, and pointed out that these are not simply cases of mismanagement or individual malpractice, but an implication of the systemic embedding of market logic into the very fabric of healthcare delivery. So while the findings point to deeply entrenched challenges, they also highlight areas where change is both possible and necessary. So here are some proposed directions to help reclaim healthcare as a public good and to realign the system with values of equity, ethics, and collective care. Firstly, there is a need to recenter socially responsive indicators in how health systems are evaluated. Healthcare leaders need to champion a different set of metrics beyond the corporate balance sheet. Quality of care, equity of access, patient satisfaction, staff well being are all critical indicators, internationally recognized critical indicators of a health system's performance. So, such an orientation therefore requires an internal accountability mechanism, like ethics committees with teeth, whistleblower protections for staff, and zero tolerance for any policies that undermine patient rights. Globally, many frameworks stress accountability as a pillar of health governance. For example, recent resolutions on social participation and accountability for universal health care encourage countries to institutionalize community monitoring and grievance redressal in healthcare. The evidence presented in this report suggests that unregulated commercialization is fundamentally at odds with the goal for health for all. And it is imperative that government and regulatory bodies proactively enforce standards for ethical practice, quality, and fair pricing. And where existing laws, such as the Clinical Establishments Act in India and patients' rights charters are in place, they have to be implemented rigorously with participatory oversight. A robust public sector forms the necessary uh, counterbalance to corporate dominance. Reinvesting in primary care would expand access, reduce dependence on private providers, and restore trust in the public health system. And medical education needs urgent attention, not just in terms of curriculum content, but in the values and cultures it fosters. So there is a need to embed ethical reflection, public health thinking, and critical dialogue throughout the training process, not as isolated lectures, but as integrated cross-disciplinary practice. And this includes creating dedicated platform within medical colleges to discuss the determinants of health beyond the biomedical and debate the commercialization of health and its consequences for clinical ethics and equity. At the institutional level, government colleges and hospitals must be strengthened And private not-for-profit institutions with a clear social mission must be supported. It is also essential to support alternative education models that center experiential learning and social accountability. Programs like the Rural Sensitization Program, Travel Fellowships, and Nirman offer immersive experiences that expose students to grassroots healthcare challenges and community-based practice, offering a counter-narrative to the dominant model of hospital-centric, market-oriented training. And finally, there is a pressing need to elevate the status and visibility of generalist disciplines, particularly primary care and family medicine. These fields are essential to building a balanced and need-responsive healthcare, and yet they continue to be undervalued within both medical education and healthcare delivery. Civil society and advocacy networks remain crucial, both in challenging the dominant narratives and in proposing alternatives grounded in solidarity and justice. And one of the biggest takeaways from this effort was that there is an urgent need for continued research and documentation, particularly how this financialization and corporatization has reshaped clinical practices, professional ethics, but most importantly, patient experiences across both private and public sectors. So, what this consultation revealed to us is not just a crisis of cost or access, but a crisis of ethics. Institutional overreach and commercial imperatives have place healthcare workers in a critical position, not just as clinicians, but increasingly as defenders of patients' rights and ethical care. And yet, the personal and professional cost of resisting these unethical practices is high. And many institutions are structured to ensure that this cost remains prohibitive. And if we believe that health is a human right, then profit cannot be the arbiter of who receives care. And upholding this right demands strong public oversight to hold both public and private actors accountable to the goal of universal, dignified, and ethical healthcare. Thank you. So before I stop talking, I just want to quickly share just some other things that happened before, and then I'll open the floor. I know I've been speaking for a while. Immediately after our presentation, there was a session on mapping the terrain of financialization and following the money, methods and techniques for holding PPAs accountable. And the next day, we attended a session titled Privatization and the Workforce and looked at the effects of privatization through a gender lens, which, of course, these are things that I'm sure all of us are aware of. But I was surprised how most people were not aware of this, though some people from countries like Kenya, even Malaysia, Vietnam, Australia, all of them felt that these were trends that especially Kenya, they were seeing a lot of this and it resonated with them. And through the gender lens, of course, we looked at many things like which we have been discussing in the last few months about how women get sidelined and they are considered caregivers traditionally. We spoke a lot about ASHA workers and their roles and how, and someone pointed out that if we expected men to do the work that ASHA workers do on a voluntary basis, on an honorary basis, we don't think that it would have reached this far. And one of the suggestions was that the next meeting like this, there should be an ASHA worker there present to be able to get a real view of what is happening and what their experiences are like. One thing that really helped me put things in perspective is Abhay's suggestion of trying to think about how we would explain this kind of symposium to the communities we work with on the ground, why we collect like this, what we spoke about, and what, if any, are the outcomes of such a gathering. And I'm aware that many of us are sometimes cynical about these international gatherings and if they really reflect the realities on the ground and whether anything useful actually comes out of it. But at this, this was my first conference at such a level. And I found that because of the current political environment in the US, with a lot of funding being cut, and because of the NHS also being at this critical juncture with a lot of internal privatization, internal commodification, a lot of the higher income countries are now relating with what they call the middle and lower income countries. There were people from Uganda, from Kenya, from Japan. Somebody from China came up to me and asked me if private hospitals really are that bad, because she was completely unfamiliar with that kind of structure. Somebody from Japan came up to Abhay Shukla and asked him if they could, send this presentation and this paper to them, because they wanted to learn from this, which really surprised us, because Japan is otherwise, though they are quite a capitalist nation, they've managed to keep their health sector um, quite grounded and community oriented and all. There are standardized rates across the country. So I found that in that sense, many people in that conference were anxious. Many of them were really worried about what was going to happen. And at the end of the day, there was the plenary where it would all be put together, and they would share their learnings. And many of them mentioned the India case studies, because it reflected to them what the possibilities could be, what it meant, what the long-term implications of such a process could be. And I met someone called David Rowland, who's part of Keep the NHS Public. And he also presented in the subsequent sessions after ours, where he spoke about how the ophthalmological services in the UK are all contracted out, and how, um, because of this, many unnecessary cataract surgeries are happening. And also many children are being undergoing many unnecessary ophthalmological procedures. And one of the major things that came up was that we find that people from the mainstream corporate are often very loud and vocal and have very good PR, or are able to say their things in very effective ways. And sometimes on this side of it, we are not able to do that. So how do we make our messaging effective? And one of the things that David Rowland suggested was that if they spoke about how private institutions were making profit because of these ophthalmological outsourcing, many people immediately switched off, because they said, what is wrong with making profit? You people are just socialists. And this many people spoke about. The second you speak against corporatization, against capitalism, immediately they call you a communist and they brand you, and then no one listens to you. So maybe to get our foot in the door, we have to manage our messaging. And he said that if we speak about the children being affected in the NHS, then immediately everyone listens. But if we use the P word being profit, then sometimes their brain just shut down and they don't listen further. So this is also something that I really want to communicate with you. And another thing was that the many people are cynical about the use of social media and the kind of marketing that it requires. And we don't have to adopt all the practices that one would be if one was a social media influencer, but we could try and use social media, since it does reach many people, to try and bring some narratives out into the public domain. Because many of the things that we talk about remains in that silo, and it doesn't percolate into the mainstream. So many things like the adult TB vaccination, like coercive sterilization in sickle cell anemia, all these things most of our communities are not aware of, and therefore they do not realize what is happening, including the misuse of the PMA insurance schemes. Um, and many of us are not even aware of the realities of these insurance schemes and how it is driving revenue into the private sector, and how it is being misused by small private setups in more rural areas, in private hospitals that are empaneled with these insurances. And one last thing I just wanted to share with you was that in one of the plenaries, there was something, they invoked something called the Chatham House Rules, which I had not heard of before. But essentially, what it means is that in that gathering, whoever is speaking, they cannot be identified. And if anyone writes about what was spoken of, it cannot be reported in a way that it identifies the speaker. And you cannot, so it's basically a closed meeting. And so it's therefore, and nobody can record anything, nobody can take a video, and therefore people can speak more openly. And everyone, so there were people from the UN, the WHO, Amnesty, Doctors Without Borders, among many, many other Public Services International, and many other such organizations. And all of them were extremely worried about the current trend of all the countries becoming more and more mm, measuring everything based on revenue, everything based on GDP, but not actually translating into actual development, about becoming more and more individualistic and nationalistic, and more people in power using language and religion and race to divide people to retain that power. And this was a universal thing. And something interesting that came up was that the special rapporteurs for the WHO and the UN were given some space to talk. And they also spoke about how, similar to the ASHA workers, though obviously with much greater privilege, they are also kept as an honorary basis, because if they get paid by the UN or WHO, then it becomes a conflict of interest. And then they are sent to some places where they are asked to report about the happenings over there, about the ground, what's happening on the ground. But very often, when they try to do that, forces within these organizations, within the WHO, within the UN, um, do their best to delay, dampen, quiet these reports, and often even end up harassing these special rapporteurs. So my aim of telling you this was that until I reached this symposium, my view was very limited to what was happening inside the country. And I did not really understand why we should try and liaise with places like I know Mike has been talking about the NHS, and you know making that connection, creating that solidarity with possibly people from who are working in the NHS right now, who want to keep the NHS public. And I couldn't really grasp why we should do it, but it clicked at this conference because of something that Anand told me at one of the governance workshops. And he spoke about how the HIV drugs initially were so expensive, and a few companies had that monopoly over creating them. And basically, the World Bank said that those who are in the lower and middle income countries who acquire HIV should just look at palliative care and not at treatment. But because of uh, the allies of LGBTQIA communities across the world together put civil society pressure and generated enough political will and pushed the WHO, is the reason we have uh, uh, you know been able to create these produce these drugs at a much more affordable cost, and we are where we are with HIV in all our countries right now because of that. And it occurred to me also because of what I learned during the CHLP about climate change, is that if magically tomorrow India and its government decides that all our policies are going to be climate friendly, but the UK, the US, and Australia, uh, Europe, all these countries do not comply, we are still cooked. So there has to be a combined effort between all of us, because right now, most of us in the world are going through very similar things, just at different stages. And all of us are equally concerned about it, of course, within these circles. But there is significant concerns, and where earlier there used to be a more paternalistic attitude of these higher income countries that they have to help us, they have to give us things. Now it's more like they are more motivated to see these processes through, because they can see that they are going in the same direction. I'm going to stop now, and I just want to mention something that Anand asked me to mention, which was that Dr. Alka from CMC has also recently started an effort to look at the privatization and how it is affecting medical practice, clinical practice, and medical education. And one of the things that she has also raised is that we should start talking about these things more, the effects of privatization, of commercialization, of commodification of everything, and debate it in medical colleges across the curriculum, and create a platform for that to happen, so that while we try and affect policy, there is also a bottom up ground level change that starts happening, and we start thinking, more and more of us start thinking critically about the implications of such practices. I also really want to thank Aparna and Anand, because I mean, I couldn't have done this without them, and of course with the support of the rest of the FEH. I think I'm going to stop here and just open it, because I've been speaking for way too long. So anyone who would like to speak and add to the discussion? Ubu, would you like to add something? Ubu and I would sit for many hours and go through each line. So I'm really grateful for Ubu's support.
Mm. It's just over a year, isn't it, since we formed the FEH?
Yes.
And I think the two concrete things that have happened are the testimonial to Supreme Court, which hasn't yet been submitted in court. And the second is this work, which is sort of pilot work. The I just want to say that, and the fact that in a period of about 3 months, we have been able to finish, put the work together and present it, and I think that's creditable. So to thank Gayatri for that. The the meeting in Vellore was, which Dr. Alka initiated, was more sort of an initial dialogue, but some of the people on the call today were there. It was not thinking through the structure of the problem, more to think of what are solutions. And different people were there and reflecting different perspectives. So it's different from sort of a FEH kind of thing where, we have similarities in thinking. But that dialogue is going to continue, and it offers opportunity to engage with people in different parts of the spectrum, some working in private sector, some working in medical colleges, and this offers the potential for FEH to dialogue with other people to think about concerted action.
Thanks, Ubu. Stanton, anything you would like to say? Avani, you were also part of this process. Anything you would like to add?
Am I audible?
Yes.
No, I think hats off to the entire FH and Kranti, especially to you. I think I was listening to a different Kranti than the one I knew. Presentation was so crisp, so clear, so hard hitting. I was actually wondering if you'd prepared it on previously or if you were just speaking ad verbatim. I think all of you set new benchmarks for us to collectively explore. I think governance, it's personally a both emotional and inspirational moment for me, seeing this sort of turnout very organically out of governance, which was like a shot in the dark. So this was very insightful and very inspirational. Ubu, Kranti, the others, Aparna, Avni, thank you so much. I mean, this has made my day basically. Loved all of what was presented. Hope to be part of more such discussions and see how Barefoot Academy can also support you in taking this to the next step. Thank you so much.
Thanks, Stanton.
Hello. The thing is that it was very clear. Your presentation and it was nice only. I have a doubt like that. The last thing, when Ubu the HIV drug thing, though you mentioned about Ubu was told that. My doubt is that because I don't know that about that. When according to all drugs, there will be a patent period or something like. So yesterday we were talking about some glimepiride or some anti-diabetic drug. So that in previously when it was entered into market, that price was very high. So no one could afford it. But after the patent period was over, it went to that market with a low price only. So is that the same happened here or any? It was any potential like any strategic movement or for the WHO or something to the third world countries or something? That is my first question. Is that happened due to the movement by the queer community people? Or if Ubu could explain this in note here also, it will be okay, like writing or something, or sharing in the documents, or it will be very benefit because I am very interested to know that's thing. Yeah, that's the one thing. And the second part, I felt it like when we focusing on the like how to tackle this. When you mentioned about the travel fellowship and RSP program, and also I thought that okay, but it want to, and also including these things into the curriculum things also, just like I think it must also be elaborated thing, kind of thing, like making the people politically aware is the thing. Like, so I don't,
Yeah.
if we can put that directly, that comment or not, that I don't know how we can put that into present or something, that thing. And other thing, one suggestion is moving forward, like thing. That
Yeah.
recently I came to know about that. The Karnataka people's Sarka something, I don't remember their name.
Yeah.
They were mobilizing peoples in Kola region to against the privatization of the hospitals there and all. So
Oh,
if we can talk with them and
yeah.
do solidarity with them, or if we can regionally conduct some studies or something to know deeply in our areas and arrange something like that movement
Yeah.
or something, will be a productive thing. That's it. Yeah.
Yeah. That's very useful, Avani. Thanks. Before Ubu answers quickly, I'll just answer the remaining 2 points. One thing is that on the fourth day, we had actually visited the UN university where we sat in a meeting with about, let's say, 8 people. And they wanted to look at what we can do next. And one of the major things that I brought up was our governance workshops, our travel fellowships, and our rural sensitization programs. And they were really interested in how this was working. And I gave them a few examples. I showed them pictures, and that's something that I also agree needs to be brought out more, and maybe a more elaborate presentation. And secondly, I was hoping Akshay would join today, but because he is part of the Karnataka movement, and I do think that you're right that we need to maybe request Akshay, or maybe Akshay and Prasanna to come and speak to us about how they've done it and how we can do it in our own cities, and at least take some learnings from there and how to take it forward. Ubu, if you could answer Avani's question.
Yeah, so in brief, uh, some key things happen. There is a clause in GATT that the Global Trade Agreement for countries in situations of emergency, public health emergency, for them to issue compulsory licenses for production which uh, uh, works against the patent. There is a clause that if there's a public health emergency, a country can produce drugs within their country. So the South African government actually did this, and the coalition of multinationals fought a case in South African court, Supreme Court, uh, uh, saying that this was not correct. At this point, there was an international activism where there was of groups across the world, which was highlighting that multinationals are preventing the access of basic drugs, and at that point, South Africa had an adult seroprevalence of 20, about 20%, 25%. So it was going to cause catastrophic death. So it became so bad that the multinationals withdrew the case in the South African court. So at this point, Cipla said they would produce the antiretrovirals at $1 a day, which was reducing the cost of antiretrovirals by 1,000-fold. This was one important event. The other was that in Brazil, the uh, the Brazil had just got its freedom. It had come out of dictatorship, and in the 90s, the first elected government in Brazil was elected, and the fought against the dictatorship was one of the pressing issues was on HIV, and that many in Sao Paulo there was the HIV was a big problem, and a coalition around AIDS was the one which fought the struggle against for freedom in Brazil. So when the first government was elected, they said that uh, that right to that unless people have right to health, it is like civil death. And they said that we have to make sure that essential drugs are available to everybody. So Brazil actually also used this clause, which was again opposed by the international pharma, to produce drugs. And both the efforts of India and Brazil actually brought down the cost of international antiretrovirals. And the other key bit was that Kofi Annan started, because of activism, started the 3x5 initiative, where to provide antiretrovirals to 3 million people by 2005. And all this actually happened concurrently, where the WHO put into a program for access to antiretrovirals. India and Brazil were able to supply antiretrovirals to developing countries across the world. And so today, actually, people don't die of HIV. So it's really a story of how activism led to this, and using international law provisions which were still available.
Thanks, Abu.
Thanks,
I
Subbu.
can send some references.
Yeah, that would be really great. I think we could circulate it in the group, and then maybe all of us could go through it. I think Chaba also mentioned that Vidya Krishnan speaks about this in her book Phantom Plague. So we could read that as well.
One point I
Aparna,
wanted to say was that
yeah.
Just listening to Gayatri, and also the presentations that she shared on our WhatsApp group, was that the while we've thought about FEH and our work as local work, I think that problems that are faced by people in different countries is very similar, and the need to work across. And one thing which I did not know was doctors in Pakistan going on strike because of the privatization, and in all the the din of noise about the conflicts that have happened between the two countries, these kind of things, we are one people, right? In the subcontinent. And I think the need to dialogue across and use groups, connect with people like FEH in other countries which are faced with, and share our own experiences. And I think, I don't know whether Mike wants to comment on that also.
Yes. Well, first of all, I'd like to congratulate Kranti on an amazing, detailed feedback from the whole exercise, including Kuala Lumpur. And I would definitely, I mean, I'm really encouraged by the the theme of solidarity across countries, because I think that the UK is really going in the wrong direction. And of course, right now, there's a talk of a big trade deal between Donald Trump and the UK, the Keir Starmer, and we don't know what the content of that's going to be, but you can be pretty sure that that health is going to be a big part of it, and we know what that will mean. So I think that we're going to need solidarity across countries, big time, to resist the kind of things that Kranti's been drawing our attention to. One of the things that struck me listening in the preparation for this thing in Kuala Lumpur, I remember that Abe drew attention to the need to have a sort of preliminary exercise to precede a much more detailed. And I just wondered whether the detailed thing is even necessary. the evidence seems to be there in profusion. And will it be necessary to have the big detailed thing? And I mean, I don't know the answer to that, but maybe we'll need to, maybe we can use the exercise that's happened in India as a sort of template to do some, similar things in, well, David Rowland, Kranti mentioned David Rowland, and the kind of work he's been doing, I guess, points to this as well. So anyway, yeah, I'll stop there, but brilliant. I think it's been fantastic, this session today, and all the work that's gone in preparation for it. It's amazing. And thanks for allowing me to join in.
Thanks, Mike. I can't possibly take the credit for it. I didn't know how to do any research before this. I don't think I still know. I couldn't have done it without all the help that I got. And you were there in all the calls as well. So to answer a question about what to do forward, we do need much more work on this, because this was not the most, even for qualitative research, this was not a structured way of doing it. It was an unusual way of doing it from what I've gathered from Abhay and from Anand. And because many people brought in their own experiences and did not strictly limit their insights to what they heard in the interviews with other people, it can't really be published as is. So I'll just take this opportunity to quickly tell you about what is the next further plan. The UNU University is extremely interested in publishing this. That is the UNU's priority. My priority is that this should become accessible and readable by our members of the community. Because those are the people who need to know that A, they are not alone, and B, these things are really happening. So the plan is that this is the plan proposed by the UN University in collaboration with Abhay, is that there is a researcher called Shweta Marathe, who's from Sati. She will not be working as part of Sati, but as an individual researcher. And she will be giving the research support for this, the academic rigor to this. Possibly, I will be helping with the data collection, and we will, this particular set of 12 people who are part of this call is not fully representative of all the different kinds of doctors, nurses that are there across India that are experiencing these things. So our plan is that by the middle of 2026, we will have done at least 30 such interviews across the country, hopefully in-person interviews, and then we will try and document them. And my aim is to also try and document as many patient experiences, because we do tend to focus a lot on experiences of doctors and nurses, healthcare providers, and patients somehow tend to get ignored, even though the whole health system is supposed to be geared towards them. So we will be looking at experiences of patients, effects of corporatization, and if there is a scope, then how the interaction between these healthcare providers is also changing. And that's the plan. And I will request the support of FEH as they've been supporting us until now. Maybe even if it's just to help us get in touch with more of these physicians physicians, nurses, support staff, and patients who may be willing to be interviewed, and therefore we can come out with a documentation that can be shared with the community at large. Aparna, I really want you to say something, because you were such a big part of this process. So if you could just share some of your experiences and how it was for you. Aparna, we can't hear you. Meanwhile, if anyone else wants to add something, please go ahead. No, Aparna, you're not audible. Okay, maybe I can ask Aparna to send in a message or something later. Hi, Suresh.
Hi, Kranti. And hello, everybody in the Kudam. I came in too late to hear anything, but the excitement of the others is making me excited to watch the recording. Yeah, that's one. Two bits and pieces of your earlier presentation, preparatory work you had shared, which is very interesting. I was sharing it with a couple of young doctors, as also dentists and nurses and physiotherapists and others. So one common question all of them are asking is, why have you kept us out?
Now we are going to include them.
Yeah. So just to add that there is a wider community of people in the health field who would like to come forward. On behalf of Barefoot Academy, with your UN University and the other work and the FEH, of course, we're all linked together, would be that we could help design a more experiential based access initiative to look at many of these issues from an experiential context outward, the same way that we did the Govern H series of workshops. So we could very well, now we have a template to improve upon. So I thought that I know Vikash and Sayantan are also here in the call. So on behalf of all the three of us, we would definitely like to help out on that part. And it's a very, very much needed thing. My mother has had a stroke, and for the last 1 month, she's at home. And the costs are like bombshells. I knew all of that, but when it hits you, then you know. And then you're thinking of the millions and millions of people who can't afford such type of things. And the type of cure, and each one says one thing or the other. So all the more reason that Govern H and FEH should be strengthened. And our team support is there with anybody, with all of you. I will check out your presentation. I'll get back to you on the call on the content part.
For sure. Thank you so much, Suresh. We obviously started with governance, so I am very grateful to Barefoot Academy. The first call I did like this, I'm sure you saw me being very nervous, and I'm slightly better at it today. So I'm really grateful. And yeah, I think that I agree, it is an urgent need now. So we should try and figure out how to take this further and create more Kudams like this. And I will definitely be in touch with you and Vikash and Shayantan to try and figure out how to do this.
Okay.
Thanks, Suresh. Also, you want to tell us about this community accessible dashboard? What do you mean by it? We have about
no,
6
actually,
minutes.
hi everyone. I attended part of this meeting few days back, in which Shayantan actually asked a question like, what is it? How do common people, non-doctors who are hit by an emergency and we have to access a private system, how do we know about rational practice or who's a good doctor and all? So that time I was thinking, is it possible to have, like something like Dr. Net has a list of doctors,
Rational practitioner or something.
practitioners, or even affordable rational practitioners. So then I got this idea, is it even possible to have this even on a WhatsApp group or something like that, no? So Shayan, yeah, I've been thinking of that question. I don't know, I couldn't attend the full thing, but I don't know if you got an answer that day. So yeah. So that's what I meant by.
Yeah. Maybe Arvindan can help us with
Yeah.
that and what he thinks about this, because he's.
Is this for knowing the information or getting the care delivery that is appropriate from practitioners?
Both.
I think just knowing the information, just knowing who is a good doctor to go to.
Okay.
Affordable, rational.
Okay, yeah. So we can certainly talk about it. The doctors that we have in our network, we don't have them as the publicly consumable information. So if we have like few hundred of doctors, not so they also are in various range in the spectrum. Some of them are extremely 100% ethical and rational. Some of them are not that rational, etc. There are, however, there are few forums that Forum of Rational Doctors. I don't know exactly the name of it, but there is one in Tamil Nadu, and there are few I've heard something like that. And yeah, about the care delivery. So there is a secondopinion.com, etc. So I can share that it is started by CMC or some of the retired CMC or doctors, etc. So there are such forums. We can talk about it and then see how to put publicly consumable information about like rational doctors involved in rational practices, right? So yeah, we'll definitely talk about that.
Thanks,
So
Arvind. I think
I just add to what Arun said. So second opinion was started by one of my teachers, and they, where people want another opinion, um, it can be accessed. I don't know the details. The other related discussion was in response to Sayantan's question was, could there be something like the NICE guidelines in UK, which is publicly available for a given condition? What is the most rational care? So NICE has two parts to it. NICE has got the professional guidelines and also for information for public. So will that be a useful contribution? These were some discussions.
yeah. Maybe what I can do is I can schedule another meeting, even if it's in a month's time, to give enough time to people. And we can have these two topics as agendas of discussion, and we can meanwhile speak to Arvindan and look at a second opinion and see what those models are, and maybe actually debate this, whether something like the NICE guidelines can work in a country like India. Because even within us, there are different opinions, and it's worth really discussing it. So I'll put it up on the group and see what people have to say, if that seems useful. I think we have just about a minute left. I don't want to, it's been an hour and a half. I just want to thank everyone for coming and listening to me and letting me share these things with you. Before I leave, just one thing that I forgot to add was that when I spoke to David Rowland, before I could tell him anything about the Kudam or the RSP or the travel fellowship, which I must say everyone is very appreciative of. It seems like one of those pioneering initiatives. Everybody, David Rowland especially, wants to come and interact with and even the people from the UN University are interested in seeing how these alternative models of education are working and learn about the experiences. So that is very encouraging. And something that David also pointed out was that the doctors who are working in the NHS have now also, the cost of education, cost of living has also gone up. So they are in a similar situation as our postgraduate students, who have obviously taken huge loans sometimes to fund their education, and therefore to then pay those loans back, they have to sometimes work in the private sector to earn that much money back. And he says that their young doctors are facing similar issues, but they don't, because they have not seen the long-term effects, they are not able to understand why they shouldn't work in a private sector if it helps them earn more money. And he felt that it would be very useful if some of us could share our experiences with them, and if they could share their experiences with us. So my aim is to just try and tell you that there are very solid, I mean, this solidarity has not just been a word up in the air for us. It has begun to mean something very solid for me. Yeah, I'll just end there. And if anyone has anything to add, otherwise we can wind up the meeting. Okay, thank you so much for attending. And I have made a folder with many presentations and documents in the Forum for Equity in Health Google account, Google Drive. And I will share that with the group so that all of you can go through. And I will also edit this recording and then upload it on YouTube and share the link with you all. Thank you. Good night. It was good catching up with you all.
Yeah. Good night, everyone.
Thanks,
Thank you.
Kranti.
Thank you. Thank you, Gayatri.
Bye.
प्रसूति आवाज आ रही है क्या हमारी?